You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello and welcome to Streetside. This is the regular podcast of the Street Medicine Institute Student Coalition. I'm your co-host, Michael Brennan, and it is with great joy that I have Dr. Shaina Shetty today with me and would like to ask her to introduce herself.
Yeah, my name is Shaina Shetty. I'm a family physician and a street medicine physician based here in Detroit, Michigan. I'm excited to be here.
Thank you, Shaina. We're so glad you're here. And I'm going to ask you to expound on that a little bit. Tell us of your journey, number one, into medicine, number two, into street medicine, and number three, into addiction medicine. Can you take us on your journey?
Absolutely. So I grew up here in Michigan, actually during the recession, right? And so at the time in Michigan, and specifically around the Detroit area, it was pretty clear to me that we have a very broken safety net system, right? It was obvious as a child. So I ended up going to college, and I think I debated between social work and public health and maybe medicine. And I remember sitting in these classes, we learn about that river analogy, right? Where there's upstream effects and downstream effects, right? And you're finding folks at the bottom of this river stream, and you're trying to figure out what's leading in there, and you're trying to figure out how to address those things. And I remember I'd sit there in these classes, Michael, and I would just be like, who's taking care of the folks at the base of the river, right? Who's there for them? Because those were my people. That's where I wanted to be. And so I decided to go to medical school, mostly to try and address that need to take care of the folks at the bottom of the falls. And went to med school and then ended up in residency in family medicine. I knew I wanted to work at FQHCs. I knew I wanted to do broad spectrum primary care, whatever that looked like. So I trained in family medicine over at UIC in Chicago. And honestly, I fell into street medicine. There was a patient I loved dearly who had benzo use disorder, opioid use disorder, was rough sleeping throughout parts of Chicago. And I was seeing him just about weekly because we were doing a benzo taper for him. And he introduced me to the world of harm reduction. He introduced me to the world of street medicine. He introduced me to an org that was supporting him. He took me there and I met the folks there and I joined them as a volunteer physician. And I felt like doing that work, that's where I met my people. Those are the people who are down at the bottom of the falls with me, right? They were deeply invested in that. So yeah, I finished up my training. I was a volunteer physician kind of throughout residency. And then this job came up in Detroit that is based at an FQHC, but it's an FQHC. My site is in connection with a housing nonprofit. So I get to do a lot of street medicine work as a part of my day-to-day job. I get to do like low barrier primary care, set in an environment that is safe and feels good for folks navigating drug use and housing instability. And yeah, it's a dream job. It's hard for sure at times, but it is a dream job. And I've been here a couple of years now.
Oh, that's fantastic. Let me clarify for our audience that FQHC, Federally Qualified Community Health Centers, and just we throw that lingo around, but some people might not know it. I'm curious, in your current employment, are you on the street or in a clinic more?
I do both. So I'm on the street usually a day or two a week, and then I'm in clinic the other 3 days a week. So a little bit of both. Yep.
And when you go on the street, do you go to the same areas or are you?
Yeah, generally. So we have like a street medicine team that's based out of our clinic. And in the city of Detroit, I think about it almost like as an escalation team. There's a lot of other student-led street medicine teams and volunteer-led street medicine teams. And when they identify someone who requires sort of like consistent care, higher levels of care, substance use disorder, interested in starting medications, pregnancy, wound care, Hep C, HIV, things like that, they'll refer them to our team. And then our team becomes kind of the continuity street medicine provider. So generally my area is on the east side of the city, just because the city is so large, and we can talk about that later, but I largely focus on the east side. And we've got a team that does west side and the Woodward corridor as well.
And how big are those teams and what are they, what is the composition?
So it is me, and then we've got a housing navigator / peer, and then we've got a community health worker. And then on a different day, we've got a different physician, and then we've got a nurse practitioner on that third day. So it's a tight-knit team. And I think that's kind of the way I like it in some ways. I think we build really strong relationships that way. My peer and my community health worker know the ground really well and know the people really well. So yeah.
Oh, fantastic. Tell us about your journey into then addiction medicine. Substance use disorder treatment.
Yeah. Again, I sort of fell into it. I think it was a residency. I was fortunate to train in a place that gave me really fantastic training in this. We were also a federally qualified health center, but also had a methadone clinic based inside of it. So I got to do a mix of methadone and buprenorphine. And I just loved it. And I think so much of it, especially from a harm reduction standpoint, like is pretty deeply intertwined with street medicine, right? It's truly centered on meeting the patient where they're at, addressing their needs as they see it. And so it felt like it just went hand in hand. When you think about the comorbidities, obviously there's so much data around this. But more than that, I think it really just felt like the clinical practice and the way of being a doctor and being a provider just felt like intuitive, right? It feels like they exist together. And so it just became a natural part of my practice, honestly.
Yeah, it's to provide comprehensive holistic care means
Exactly.
doing this piece of it. Tell us about Detroit. What does the point in time count look like for numbers of homeless? And then I'm also curious about the prevalent drugs.
Yeah. So Detroit is really unique, right? It was a city that historically has been built for 2 million people and now has about 600,000 people currently living there. So by land, it is really, really quite large. Compared to other cities, we don't have encampments in the same way. There are a fair amount of abandoned buildings or older structures where our folks actually reside in those buildings. And so our pit count, I think, is consistently not catching all of our folks. The pit every year shows about 1,500, I think 1,400, if I'm getting it exactly correct. I think on the ground, we know that number is higher because you're not capturing folks who are living in these abandoned buildings. I think that the need is quite high in Detroit. I think that is a history of disinvestment and structural racism and redlining and white flight and all the things that hit a lot of other post-industrial cities, but at a much harder level here in the city of Detroit. So I think if you include folks who are couch surfing and all the things that come with a lack of generational wealth, right? Those numbers are likely much, much higher. In terms of substance use here, I feel like it reflects a lot of the other Midwest cities. We see a lot of opioid use disorder, a lot of cocaine use disorder, a little bit of methamphetamine use disorder, largely coming from the west side of the state, but that's new. I think I've got a couple of cases, but not more than that. Yeah, that's mostly about it.
Are you seeing the xylazine wounds?
We are, yes. Yeah, we're seeing xylazine, and then medetomidine has been the newest contaminant in our drug supply here. So yes, we're definitely seeing a fair amount of xylazine wounds.
Tell us more about that. Tell us more about the new contaminant.
Yeah, medetomidine.
Yeah.
Yes. So medetomidine is also a veterinary tranquilizer. It's considered to be stronger than xylazine in some way in its tranquilizing effects. But the reported effects of it are about the same. Folks feel it as sort of that sedation that comes with taking a tranquilizer. The thought right now from what I'm seeing from early data is it doesn't seem to cause the same wounds. Those wounds are really attributed to xylazine, but I think the fear is just the shifting drug supply, right? And the increased risk of overdose related to that. We're also seeing some carfentanil in the city of Detroit. We've had a couple of deaths coming from Wayne County with carfentanil, and that is a version of fentanyl that is about 1,000 times stronger. So it is much more intense. So I've been doing a lot of talking to my patients about that.
Tell me, I don't know about this. Carfentanil?
Carfentanil, yep.
And it's a concentrated form of fentanyl.
Exactly.
Okay, with a much higher overdose prevalence.
Exactly.
Okay.
Yeah.
Tell us about your efforts in addressing the opioid use disorder in your patients. What are you doing for harm reduction?
Yeah. So what's kind of nice is we're both a street medicine team and a certified harm reduction team, which means I carry all of the supplies for safer use on our vehicle. So everything from straight pipes to bubble pipes to hammer pipes for folks who are smoking, different syringes based on how a person or what size a person would require. We've got testing strips. I try to keep up to date with whatever we're seeing in the drug supply. So fentanyl, xylazine, medetomidine, sharps containers, Narcan, all of that. And I think that's been really incredible because I think offering those harm reduction supplies along with our team really just helps us build a strong relationship, right? And so really being able to offer that, I see people weekly generally, especially with these wounds, right? Continuing to offer them safer supplies, building relationships, building a sense of what's important to this person. And then eventually, if they're ready and when they're ready, also knowing that I can connect them to treatment on our vehicle. For a lot of my folks on the street, the goal is not necessarily cessation of drug use, right? It's really, really hard when you're rough sleeping. But I do think there's really good support for using buprenorphine as a harm reduction tool, really to move towards more controlled use, to move towards overdose prevention, and that is often what my folks will name as their goal.
What do you see as the pathway into a illicit use disorder? What's the pathophysiology, the pathogenesis of that?
Yeah, it's a good question, and I think it's different for for every person, right?
Right.
I will often ask my patients like what their story is, right? Where did it start? What's your history? And I hear all sorts of different things, right? I hear folks whose parents may have used when they were kids, and that was how they were introduced, right? So maybe some genetic component. I hear folks who got in a really terrible car accident and as a result of medical trauma and difficult things there. We started on pain medications, then escalated. And then so many of the people I see, Michael, are just folks who have suffered, right? Who've been dealt a really, really hard set of cards. And use becomes a way of managing anxiety, depression, bipolar, trauma, PTSD. It helps folks feel normal in some way or feel like they're able to deal with it day to day. And so it's different. But I think, often use, I think it's so interesting because there have been so many studies, I think, to really like try and qualify like how does addiction happen, right? And I think a lot of families ask this question, a lot of my patients ask this question, and I don't think that there is a clear answer. And I think that that's part of what I love so much about it is you have to sit with the person, right, and really understand them and really understand their history, their story, and what they want. That's the only way to do it. So, yeah.
When it comes to patients self-medicating their depression, anxiety, trauma with
Yeah.
illicit drugs, what do you do to get at the root of those problems?
So much of it is just conversation, I think, and relationship building. I think for many of the folks I meet on the street who are at the place where they're rough sleeping, possibly secondary to their substance use, at that point, there's not too many family connections, right? And so I think building relationships and helping people understand, what they may be navigating, helping them realize that there may be pathways to feel more therapeutic relationships is tremendously helpful. I also, I think that there's been a lot of mixed data about this coming out from the psychiatry folks, but I actually feel very strongly about treating underlying mental illness. So go ahead and start that SSRI, start the second gen antipsychotic, start whatever we need to start to help manage those symptoms and help this become easier to navigate. So I'll go ahead and do that as well.
I'm curious, are you using long-acting injectables on the street?
Yes, 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 yes.
Tell us about that.
Yeah, it was I think I was really quite nervous about it as I got started because I'm, family medicine. But it is so challenging to navigate psychiatric care. And my first patient was someone who had at this point, because of his disorganized behavior, been kicked out from a lot of the homeless service providers. So was not able to access the soup kitchens, was not able to access the shelters secondary to these outbursts. And we also could not figure out a way in the complicated system of community mental health to get him into an appropriate psychiatric provider. And so it became sort of like a risk benefit, thought process, right? At this point, this person, it's cold in Michigan, it's cold in the wintertime. We need to do something. And so I consulted with a psychiatry colleague who guided me on dosing, guided me on his last admission at her hospital. And we started doing the injections, and it was transformative. Like his ability to engage now with street outreach providers, with housing navigation, it's everything. So it's definitely an area I think I need to explore personally in my practice a little bit more to feel more confident. But I'm so grateful for psychiatry providers who understand that, primary care and psychiatry can collaborate to really meet those needs.
How about psychotherapy? Does that happen on the streets?
I think so. Unfortunately, my team does not have someone who is, certified as a psychotherapist with any social work degree or anything like that. I think intuitively, I think it happens all the time through the relationships we build. So 100%, I think it's there. Yeah.
Yeah, somewhat informal, but it's happening.
100%.
It's
Yeah.
happening. Building rapport. We had Liz Fry on this podcast recently, and she said something I thought was very striking. That for trauma, for chronic PTSD, the thing people need, the antidote for that, is to build trusting relationships.
Yeah.
And I see that as one of the prime movers in street medicine, is just to build social rapport with patients, to build trusting relationships. And with the social relational poverty being one of the drivers of homelessness, it seems like where we can really make a difference.
Yeah.
Would you agree with that?
100%. Yeah. Yeah.
Yeah. Okay, so you've got your patients that are using illicit substances. Let's just say fentanyl, opioid use disorder. What therapies can you offer them, and what does your program look like for medication assisted therapies?
Yeah, so there are, the three major FDA approved medications for opioid use disorder. We've got methadone, we've got naltrexone, we've got buprenorphine. Methadone is challenging to navigate, right? Often requires daily dosing. And in the city of Detroit, actually Wayne County requires a separate intake process through the community center behavioral health center. So it's a multi-step process that is challenging for a lot of our folks that are rough sleeping. Naltrexone is an opioid antagonist. We certainly can use it. I don't use it often on the street, honestly, because there's not good data around overdose reduction. And for me on the street, and I think generally as a doctor, like my number one goal is overdose reduction. But if someone feels strongly about it, certainly it is an option. Buprenorphine is largely my go-to. There are a couple different formulations of buprenorphine. There is just buprenorphine monoproduct, which is known as Subutex. There is buprenorphine naloxone, which is known as Suboxone. And then there is long-acting buprenorphine, and that comes in two forms, Brixadi and Sublocade. I largely on the street do usually the Suboxone film because they're easy to control and easy to cut. And I find that most of my folks here really like to do what we call microdosing or low dose initiation. I think this is largely a regional practice because I know when I trained in Chicago, folks there really preferred macrodosing. And so I think it depends on who you're working with. And I also think a fair amount of this is community buy-in and what folks around them are doing, right? So in my practice, I'll usually counsel folks to take one of those 8 milligram strips, cut it up into 8 pieces. When you start to feel early withdrawal, take a tiny piece, another hour, take another tiny piece, build it up in your system slowly. The goal for the first week is just to get Suboxone or buprenorphine in your system, right? That is the number one goal. And I'll tell them that that's sort of the approach. If they do feel worsening withdrawal symptoms, really the way through is just more buprenorphine. So loading it up. I've been trying to do more long-acting injectable buprenorphine on the street. I think I've got some community buy-in in one of the parts of the city, but it is a hard sell, I think. Getting a monthly injection when folks are still pre-contemplative about their goals, it's a hard thing. But I do think there's a lot of utility for it, especially when folks feel very strongly about, maintaining reduction in use and feel comfortable with moving forward. I usually will use either Sublocade or Brixadi. What's kind of nice is Brixadi is a newer long-acting injectable that comes in a couple of different formulations. So you've got a weekly injection, you've got a monthly injection. And there's newer data, I think, coming out of the folks in New York and On Point, where they're actually really using Brixadi as a way of replicating that microinduction that I do through the films. So I'm excited to see if anyone is willing to give that a shot here. I haven't gotten anyone taking me up on it, but it is an exciting option. And then Sublocade is that monthly injection that I'll largely find folks on the street too and do.
Yeah, we've had trouble getting buy-in on the Sublocade.
Yeah.
We make it available and we say a once a month shot and people shake their heads and say, give me the films.
Yeah.
Is that your experience?
100%. Yeah. And I think some of it too, some of my folks where someone was telling me they were part of like an early study for the injection. And so I think that left some bruising and scarring that they were hesitant about. And there's a lot of rumors around that. A fair amount of folks that I take care of are also sex workers, and it does leave that nodule under the skin that I think folks feel like is, it's a sign. So,
How about diversion? Do you worry about it, or do you take a fully harm reduction approach?
I largely don't worry about it. I think I give folks the tools, and they are welcome to use it in the way that they would like to use it. And I think that as long as I can, document and tell a person that this is what I would recommend. After that, I've done my part. And I think everyone deserves a shot, right? No matter what. And if they can verbalize a plan for continuing the medication, that is enough for me. And our overdose rates here in the city, honestly, Michael, are still quite high. But throughout Michigan, they've decreased. But here in Detroit, they're still increasing. And so at the end of the day, if it doesn't go on the patient I'm prescribing it to, like maybe it goes to someone else. And I do see a fair amount of folks who, picked up some and then give me a call. And they're like, it's gotten kind of expensive to keep buying this. Like, I'd like to get it prescribed. And I'm like, wonderful. Let's do it. That sounds great. So no,
what's the going rate on the streets?
$7 a strip right now.
$7 for 8 milligrams. Okay.
Yep.
About the same in Rochester, five to 10, but it varies. Yeah. So we try to flood the market with buprenorphine.
Exactly.
hope it gets in people's hands.
100%.
Tell me about the support you offer patients that are trying to get off fentanyl. I mean, obviously the medication is a big piece of that, but what other support do you offer?
Yeah, I mean, comfort medications are always an option, right? So to really help with the symptoms part of things, we'll do Zofran, we'll do Imodium. With the xylazine withdrawal and medetomidine withdrawal, I've really liked using lofexidine, which is now covered by Michigan Medicaid. And then clonidine would be the other alternative that's often covered in other states. They both act on the alpha receptor, so tends to be help with that, like anxiety, agitation, things like that. And then so much of it, I think, is like the pre-contemplation, right? So I will often give the script and then I'll come back the next week and I'll be like, how'd it go? And folks just haven't started it yet, right? And I think so much of that is I think just understanding what the barriers are, right? What's going on? Is it fear of precipitate withdrawal? Is it that we're not ready to make this change yet? Is it that we feel like we need additional support? I think that is really just like continued engagement. And I had one person who took about 3 months. He held the script. He didn't sell it. He held it, but just took 3 months of like weekly check-ins to sort of be like, are you ready? Are you ready? Then 3 months in, he did it, and he's now consistently on it, right? But I think that's the beauty of it, is you're there to support until someone is ready to start. Yeah.
I would like to think that we are all addicted to something.
Exactly.
I believe that,
Exactly.
and that we all can understand ambivalence.
Exactly.
Any of us that have tried to give up one of our little addictions, we get ambivalent about it.
Yep.
So I think it's only reasonable that our patients would be the same.
100%.
Tell me about crack cocaine use in
Yeah.
Detroit. Is that prevalent, and do you prescribe for it?
It absolutely is. I see a fair amount of it. I do prescribe for it. I mean, off-label, I'll use Wellbutrin. It's usually my go-to as long as there's not a co-occurring seizure disorder. That's usually what I'll start with. And honestly, we'll just kind of go from there. Largely, I'll tackle most of my folks have co-occurring opioid use disorder and cocaine use disorder. I usually don't see just single cocaine use disorder. There's a few folks I see in that category, but I'll usually I'll tackle the opioid use disorder first, just because the risk of overdose is higher. And then I'll go to the cocaine use disorder next.
Is topiramate anything you use?
I have been reading the data on it. I would like to use it. I have not used it yet. I think it's compelling data, but we're just not there yet. Yeah.
Okay. And you get secondary benefit with the bupropion.
Exactly.
The Wellbutrin, right?
Exactly.
For a host of other problems.
Exactly.
Yeah. Well, this has been great, and you've answered a lot of my questions already, but what do you find most challenging in this work?
Oh, I mean, I think it's just witnessing the brutality of it all. I think we're often caring for folks who've slipped through so many systems, and seeing that day to day can just be really, really challenging. And I think often feeling like, you're sitting with this person through some of the hardest moments, and bearing witness to that is a really, really hard thing. So yeah, I think that's been the hardest part of all of this. I think the joy of it too, though, is that I have never felt alone in doing this work. And I think that's the beauty of it, especially here in Detroit, where so many of our folks are, hidden in different abandoned buildings and harder to find. So much of what I do is based in connection and in working with our collaborators and in finding folks together, and seeing them together. And so I think that's the beauty, is I've never questioned like my meaning or my purpose in this. And I always have people to remind me of it, Yeah.
Shouldering each other up,
Exactly.
as Vicki Reynolds would tell us. Yes.
Exactly.
Do you want to tell us a story, patient that you're really, I don't know, proud of, or that went really well, and you felt really useful?
Yeah. I had a patient actually last year who was pregnant with twins. They were they had fetal growth restriction. And I'd met her as she was discharged from the hospital. She actually ended up leaving AMA with opioid use disorder, and this newly defined pregnancy. And so they discharged her to the street. We went to her encampment, and it was actually a friend of hers that I'd already known who showed me where she was sleeping. And so I met her there, and we did most of her pregnancy care in the street. She was pre-contemplative about her goals around use, but was really thinking she wanted to parent, and was also rough sleeping throughout this time with twins, which was a really, really difficult thing. And I think, identified her when she was around 20 weeks. Because of the high-risk pregnancy, I would see her just about every week. I would drive her to her ultrasounds and then get her to the places we needed to go. And about early in her third trimester, she decided, I want to give buprenorphine a shot. I really do. So we ended up getting her a direct admission to the hospital, because when you're pregnant, you can do that. And got her started on buprenorphine, and she did really well on it. Fortunately, her housing lined up. So as she was discharged from there, she ended up in her housing placement, which was awesome. And she delivered the twins. And what's beautiful about it is she is, I think in the hospital had been thinking about what her goals were, whether she was in a place where she was ready to parent. And I think identified that she was not there yet, but she could find a family member who was able to take these twins in. And that's exactly what she did. And I now know her. She's about a year later now, and she's currently about to navigate getting like custody of her kids and, reparenting, which is beautiful. And I am just so proud of her for really thinking about what she needed in the moment, what she was ready for, giving herself time and grace to make herself ready to parent. She now has a job. She's working on getting her degree and is about to be the parent to two beautiful, beautiful twins. And it's an amazing thing to watch and bear witness to, because that, is what she told me she was hoping for.
Really keeps us going, doesn't it?
Yes, it does.
Like when you just need a few of those every month or two. Yeah.
Those wins are everything.
Shaina, I've really been enjoying our conversation. We're coming down near the end. Is there a question I haven't asked that you would like to answer?
No, I think you've asked all the questions.
Have we covered it?
Yes.
Okay, because we ask all our guests to answer the question, if you could do one thing to make the world a better place, what would it be?
Ooh, I think it's to keep holding space for hope, because I think hope is what makes this possible. Yep.
Hope. Thank you. Thank you. And then I want to ask as well, you obviously have done a lot of study and self study on addiction medicine. What are there resources out there you would recommend for folks?
So there's a fantastic book actually about just like the history of addiction by Carl Eric Fisher called The Urge, that I think is really, really excellent as just a concise history as to how do we get here from a policy standpoint and from just a research standpoint. He's a psychiatrist who also navigated alcohol use disorder, and so it really reflects on it from a personal space. Outside of that, I think the Curbsiders Addiction podcast has been really, really excellent. They do really good, relatable, small pieces of episodes that I'll take as I drive. And then the SAMHSA the PCSS, so Physician Clinical Support Service, I think is what it stands for, but feel free to correct me if I'm wrong. They have a great series on alcohol use disorder that's been really, really helpful.
Oh, that's great. That's great. Thank you for that. And if our listeners wanted to connect with you, how would they do that?
Yes, I don't have a website or social media, but my email address is probably the best option. So it's SSHETTY at Chass Center. So it's CHASS center.org.
Thank you. That's SSHETTY at chasecenter.org.
You got it. ChassCenter.org. Yep.
Chass Center. Great. It's been a delight to have you on our podcast. I would like to come visit you in Detroit and accompany you on rounds and see the great work that you're doing. And you're always welcome to Rochester. Those of us up here on Eastern Standard Time. And this will be published on Spotify and Apple soon. So
Perfect.
we look forward to seeing you at the next symposium for the Street Medicine Institute.
Absolutely.
Thank you, Dr. Shaina Shetty.
Expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice and instead see your own provider for medical care.